So good evening everyone and welcome to this new series on Ortho TV A to Z Orthopedic Oncology series, and I'd like to thank Dr. Abhijeet Salunke as the convener of this series to taking this new initiative. So over to you, Dr. Abhijeet, to begin the first episode.
Yes, sir. Yes, sir. Thank you very much, sir. It's really nice to have a series on orthopedic oncology, and we will see that we'll be dealing with all the aspects of orthopedic oncology, and we'll introduce this topic. So I'll be sharing my screen, and so we'd like to introduce this topic to everyone. So it's A to Z of Orthopedic Oncology, a webinar series, and this is the first webinar, and we will be focusing on all the aspects of orthopedic oncology. So first we will start from the clinical features, then the investigations, and next is radiology. So that is very important investigation. So after this, in next lecture, we will have other aspects of radiology. We will have CT scan, MRI, followed by PET scan, followed by biopsy and hair force. All the lectures will have a continuous series with aspects of orthopedic oncology. And today is our first webinar on this topic. So I thank Dr. Ashok Shyam sir and Ortho TV for supporting us and initiating this webinar series on Ortho TV. So I'll welcome all the faculties today which are present with us. So firstly, I'd like to welcome Dr. Janith Singh. He is a consultant orthopedic oncosurgeon working at National Academy of Medical Sciences, Kathmandu, and he has been trained extensively in orthopedic oncology. He has done his clinical fellowship at Canada, Mount Sinai Hospital under Dr. Peter Ferguson, and he's working in Nepal and doing extensive work in orthopedic oncology. He's one of the eminent faculty in this field in Nepal. And secondly, we have a young faculty, Dr. Rishi Poudel. He is working at Nepal Cancer Hospital Research Center, Kathmandu. He has been trained in orthopedic oncology. He has done his fellowship in Malaysia and in India, and he's working at National Cancer Hospital, Kathmandu, Nepal. Next, we have two faculties who are supporting this program. So one is Dr. Ashok Sham sir. We all know him very well. So he's a known face of Ortho TV and Indian Orthopedic Research Group. So we thank him for helping us to start this webinar series. And second is Dr. Neeraj Bijlani. He's again a known face of Ortho TV and Indian Orthopedic Research Group. So what is the agenda of today's program? So we will have introduction that is given by me. Next will be clinical features, symptoms, and examination in patients with bone tumor. So any patient presents with us to in our OPD, what are its clinical features, what symptoms, sign he is having. So that will be discussed by Dr. Janith Singh. Next will be followed by investigations, which will be symptoms, which will be laboratory tests, radiograph, MRI, CT scan, and PET scan. So we'll introduce this topic by Rishi, Dr. Rishi. Next will be A to Z RAM, that is radiograph assessment method for bone tumors. So that will be discussed by me. So we will have all these three topics, and then we'll have a discussion with all the faculties. So we would like to start the program, and Dr. Janith Singh will be starting his lecture on clinical features, symptoms in patients with bone tumors. So Dr. Janith, you can share your screen and start your presentation. So I'll stop sharing of my screen.
Okay, thank you, Abhijeet.
Yeah.
Can you see it now?
See your screen.
Okay.
Yeah.
Okay, thank you, dear Abhijeet and Dr. Ashok and Dr. Neeraj and entire team of IORG and Ortho TV for giving us this opportunity today. I'll be talking about clinical examination of bone tumors. I was thinking in this day and age where we use technology so much, be it in radiological diagnosis or histopathological examination, what's the role of clinical examination? And I think no matter what technology we use, clinical examination will always be important. I will start with this little case that we had, a little trouble that we had with this case, in which it became so important for us to go back to our basics to come to a diagnosis. So we had this 15-year-old girl who was diagnosed as having fibrous dysplasia. And so she underwent biopsy, which proved it was fibrous dysplasia, and we did a protective nailing for her. And she was doing well for 2 years. And then a couple of months back, she presented with sepsis. The first thing that struck to me when I saw her for the first time was the exophthalmos that she had. So from that, we sort of went back again, tried to do a head to trunk examination, and we found a lot of cafe au lait spots all over her trunk. Then we sent a TFT, it was all over the place, it was completely deranged. So we made this diagnosis of McCune-Albright syndrome in this girl. Had we done a thorough examination of her in a first admission, we probably would have come to that diagnosis then and there. So, this is exactly the theme of today's presentation. So don't miss the forest for the trees. When you're just looking at one component of the patient, when you're just seeing the X-ray or just seeing the limb, then you tend to miss out on all those other things that may be imperative in the management of the patient. So I'll be broadly basing myself on these following topics. So how do patients typically present and special considerations. I'll be talking about these subheadings. I'll talk about age-wise distribution of bone tumor, then what to look for in history, and then clinical examination. Now, this is an extensive chart. As an orthopedic surgeon, as an orthopedic resident, anyone who's interested in orthopedic oncology, you should be knowing this. There's no point in going in each and every one of them. As you go on practicing, you get more and more adept to it. But the thing is, there's a lot of crossover. Sometimes, lesions that you think would be commoner in kids might present in adolescents and vice versa. So it's not a hard and fast rule, but you should have a general idea about the different bone tumors and cancers presenting in different age groups. Now, when you come to history, you always get this history of trauma. They always point towards some sort of a traumatic incident that led to the swelling. But is it really the cause of the tumor or the sarcoma? We don't know. A lot of time it acts as a pointer towards something that's going wrong at that particular site of the body. But does it actually lead to sarcoma? It's a matter of debate. And a lot of times, trivial traumas, especially in kids with a simple bone cyst, they will present for the first time with a pathological fracture, and then only you make a diagnosis of simple bone cyst. Similarly with non-ossifying fibroma and other benign tumors. Now, needless to say, if the mass of if the lump or the pain, it's getting worse by day to day or by a couple of weeks, then it's most likely a sarcoma. If it's taking months, then it may be a sarcoma, or it may be some sort of a benign aggressive lesions. Sometimes they may take years to develop, like some low-grade malignancies, some fibrous benign lesions, they can take a long time to develop. Paget's disease is known to be there in the body for a long duration before it makes a patient ill enough to come to you. Now it's very important to talk about pain, because it tells you a lot of different things about regarding the diagnosis of the patient and how you are supposed to manage the patient. So the three broad type of pain that may be present in patients with bone tumors or cancers are mechanical pain, night pain, and rest pain. Mechanical pain is somewhat confusing because it can be present in other disorders as well, especially degenerative disorders or developmental disorders. So you have to know that patients with bone tumors can have mechanical pain due to osteopenia or deformity that leads to abnormal weight bearing, or if there is an impending fracture that can also cause some sort of a mechanical pain. Night pain is classically seen in osteoid osteomas, but we know that a lot of malignancies can also cause night pain. rest pain. Now, it's very important to know that when someone has rest pain, it can be due to tumorigenic pain, because the amount of tumor cells in that particular bone, in that particular lesion, is so much that the patient has pain even when he's resting. It could also be present if there's a fracture or a microfracture or pre-fracture state. And sometimes if there is marrow conversion, if there is infiltration of the cancer cells into the bone marrow, it can also cause rest pain. Now, I would always say, pain is protective. If there's pain early on in the disease, it actually, brings the patient to you. In our part of the world, in the Indian subcontinent, patients usually take pain as the most important factor before deciding whether to go to the doctor or not. And a lot of times in those malignancies, pain is often not the first feature that comes forth. There's a swelling, and then there's a lot of other things happening around before the pain happens. So patients usually present late. Now, if there's a sudden onset pain on an existing bone lesion, which might be a case in patients who already have a diagnosis of some sort of a bone tumor, it could be due to a fracture or microfracture, as in osteochondromas or enchondromas or non-ossifying fibromas. Now, interestingly, in some patients who have fibrous dysplasia, if they have this acute sort of pain, it could also be due to this weird cystic dysgenesis that happens within the tumor. And if there's a growth associated with the pain in an existing bony lesion, it could be, something as simple as bursitis or tendinitis, or it could also mean something more sinister like sarcomatous transformation, like in case of MHE, which is multiple hereditary exostosis or multiple enchondromatosis, it can be conversant to chondrosarcoma. Similarly, in case of fibrous dysplasia, it could be conversant to osteosarcoma, fibrosarcoma. In Paget's, it could be conversant to osteosarcoma. This is an example of stalk fracture in a case of osteochondroma. Now, this is a case of fibrous dysplasia, whereas this, if you look at the MRI, there's a homogeneous cystic sort of appearance of the entire lesion, and that was the cause of the pain in this patient. Now, another example, this is, I think, from Japan. So figure A is X-ray of the patient when he was around 17 years old. So they diagnosed it as a case of fibrous dysplasia and put in a radiolucent cement. I don't know, we don't have radiolucent cement here, but I think they use radiolucent cement in Japan. And then after many, many years, in his 30s, he developed this pain, gradual onset pain in the same site. And the MRI was done, and it shows distinctly different sort of signal changes in the proximal femur. So they did a biopsy, found out there was osteosarcoma arising from fibrous dysplasia. Now, if you look at this resected specimen, the red part denotes the portion where there was sarcomatous degeneration. The black part is where the cement initially was placed on, and the blue part is the remnant fibrous dysplasia. Now, when I say there's a chance of malignant degeneration of fibrous dysplasia, it's a very rare occurrence. You don't have to, from tomorrow onwards, you don't have to go in and for every patient of fibrous dysplasia, you don't really have to look for or suspect osteosarcoma happening there. It's a very rare occurrence, but it should be in the back of your head. If the symptoms don't match up, if there's a very different sort of progression of fibrous dysplasia, then you should have it in the back of your head that there could be a malignant transformation. Now, past history of radiation exposure. I put this especially because as oncosurgeons, we tend to deal with a lot of patients who have had radiation for some other causes, for some, for some pelvic malignancy, some, especially CS cervix patients, they get radiation in the pelvic region. And also in sarcomas, you tend to give radiation pre-op or post-op radiation. So we get a lot of these patients. And so it can cause a plethora of problems in the skeletal system at the site of radiation. So this is, I think, a case report from Harvard in which this lady had whole body radiation before bone marrow transplant for AML. And she went on to develop this sclerotic looking lesion in his left subtrochanteric region, and it was biopsied. When they did a biopsy, they inadvertently they fractured the femur, the bone from the pathological side, and someone went on to put a DCS there, and later on it came out to be malignant, and they had to convert it to an endoprosthesis. So radiation-induced sarcoma is a possibility. By definition, it should happen at least 8 to 10 years after the radiation has been given. So it occurs usually at the site where the maximum radiation has been given to. Now this is interesting. So this is from an article by Jaffe himself. So Jaffe reported this case of a young boy who had undergone radiation therapy for LCH long time back, and went on to develop osteochondroma at the site of radiation. So radiation-induced osteochondromas also do happen, although very rare. So it's usually more common in patients if they have received radiation when they are below 5 years of age. Another case, this is from Nigeria, I think. So they published this report of a woman who had radiation given to her pelvis, and she went on to develop osteonecrosis of her left hip. She was weight bearing on it and had this collapse later on. So we actually get a lot of these patients. In my memory, we've had this woman who needed bilateral hip replacements after pelvic irradiation. After, I think, 5-6 years had elapsed before she developed osteonecrosis of both her hip joints. Sometimes it's difficult trying to make a diagnosis in these patients because you're worried about whether there's a metastatic bone disease or whether it's just radionecrosis. So if you look at this picture published in AJR, this tells you of all the areas where you can get insufficiency fractures following pelvic irradiation. It is more commoner towards the sacral ala and less commoner towards the acetabulum. But as a clinical, as a clinician, when examining these patients, you might find odd areas where you find lumps and bumps, which may actually be a periosteal or healing response to these insufficiency fractures. Now I'll come to general examination, and I'd like to be very specific to patients with bone tumors. So patients may present with fever, and it becomes very difficult to sort of differentiate it with other conditions like infection or inflammatory synovitis, especially in Ewing sarcoma, leukemias, some cases of eosinophilic granuloma, LCH, even in multiple myelomas. You can have fever, and sometimes even in metastatic diseases, you can have low-grade fever. So it may not really be easy to differentiate whether it is fever due to infection or due to tumor itself. Now, cachexia, pallor, cyanosis, edema, everything that you see in a case of a patient who has a long-standing bone tumor may be present. I mean, you can find all these features in a patient with long-standing bone tumor or cancer. And it's interesting, in cases of bone tumor, you're not really concerned about the lymph nodes, but in our subcontinent, because patients present very late, in which the tumor or the cancer sometimes invades into the skin, the dermal tissue, you can have lymph node, reactive lymph node at least in the draining basin. Now sometimes even there's you can have lymph nodes that harbor tumor cells. So it's always a good idea to do palpation of the draining basin. So large sarcomas and lymphomas, and especially margolins, it's sometimes very problematic when you deal with margolins ulcer, because a lot of times, when they are treated in the periphery at non-specialized centers, the doctor might opt for an amputation in these cases without, really looking for the status of the lymph nodes. And after a year or two, they develop this lymph node in the draining basin, and it can cause a lot of problem for the patient. It can even migrate proximally and cause metastatic disease elsewhere as well. So this is a case in which there's a marginal ulcer in the calf, and there's a lymph node present in the inguinal region. And if you see the PET scan, there's a hot uptake at that site. So this is most likely a metastatic disease. So unless you know what to look for in clinical examination, you're going to miss this. This is an X-ray from our own patient who had a biological reconstruction of his femur 2 years back, and now this is his condition. So this was sent to me by one of my junior colleagues in the periphery. So he's having all the symptoms of metastatic lung disease, including dyspnea, pleural effusion, collapse, everything. So you have to check for the respiratory system as well. I remember a patient who had monoplegia as well as vision loss and multiple seizures. It was due to a metastatic osteosarcoma that went into her brain. So it's important to examine the nervous system as well. Now, when we talk about GI system, pelvic bone tumor is the one that you see in the bottom. It's a pelvic chondrosarcoma. So they tend to be very indolent. You're not able to palpate anything until it's too late. They don't really protrude much out of the skin because there's so much of space in the pelvis itself. So it keeps on growing and growing. And if you see the picture at the top, that's a picture of a renal cell carcinoma. So if you're in the OPD and if you see a 50, 60-year-old gentleman or a lady with an X-ray that shows a very light, aggressive sort of lesion, then it's a good idea to just palpate the abdomen to see if there's any mass felt, because RCC, it's a pretty common thing to see in orthopedic oncology practice. You tend to see lesions that are very lytic and very aggressive looking. And if you do a CT scan, the RCC shows up. And if there's a history of GI polyps or tumors or malignancy or PR bleeding, that can also indicate towards a metastatic disease. For instance, this is a case report from India in which you see a gentleman with multiple osteomas in the head. And when they did a barium enema follow through, they see there's a stricture in the sigmoid region, which is due to the multiple polyps. So this is actually a case of Gardner syndrome. So because you're seeing a lot of multiple osteomas in the head, you want to think beyond. And then when you know that there's a syndrome called Gardner syndrome, in which this sort of things happen, then it's easier to manage the patient. Now, ENT-wise, it's always a good idea to see the patient's neck. Sometimes they have frank swelling there. It could be goiter, it could be parathyroid adenoma. Intraoral malignancies are very common in our part of the world because of tobacco chewing. So we get a lot of these patients having very odd type of bone metastasis. And in breast, it's very important to ask our patients, ask the patient in front of you whether they have had any breast surgery done in the past, because a lot of times they would have had surgery done like 7-8 years back, and unless you explicitly ask them whether they had any sort of surgery done, they will not tell you. And when you look at the X-ray, you see this metastatic looking lesion. So it's a good idea to ask them, especially in case of female. Similarly, in reproductive system, if they have a history of fibroids or cervical cancer or uterine cancer that has been treated, it's important to be on the know, because you might have instances in which you do a biopsy of a bony bony lesion which looks lytic and comes out to be leiomyosarcoma. And when you elaborate the history, you find that this particular patient has had a fibroid uterus removed many years back. So it changes the implications, because that fibroid uterus, if you can imagine, could harbor some sarcomatous foci that could have led to this late metastasis. So suddenly what seemed like a primary leiomyosarcoma of the bone is actually a metastatic disease. So it's very important to know this. Now, cutaneous finding is very important to, like I showed in the first case, it's very important to know there are syndromes in which you can have cutaneous markers, especially cafe au lait. So if you see cafe au lait patches, it could mean anything from neurofibromatosis, Jaffe-Campanachi syndrome, or McCune-Albright syndrome. In case of Langerhans-Sells histiocytosis, almost half the cases have lesions. So just go through the picture. So this is a case of neurofibromatosis. We all know how it looks like. So there's C stands for cafe au lait spots, patches, and then N is for neurofibromatosis nodules. And there's also axillary freckling. So that's a case of neurofibromatosis. This is a case of McCune-Albright. So there's polyostotic fibrous dysplasia with cafe au lait in the trunk. Now the difference between neurofibromatosis and McCune-Albright is that the cafe au lait patches in McCune-Albright tend to have a jagged border as compared to those found in neurofibromatosis. And this is a case of LCH in showing those erythematous papules and macules with petechiae. They are mostly limited around the scalp area and pre and post auxiliary areas. The picture on the right shows an unrelated patient with LCH involving ischial tuberosity. Now, if you find soft tissue lumps elsewhere, if you're examining a patient with a bone tumor and you find lumps elsewhere, then it can also help you in clinching the diagnosis. Like if there's a patient with multiple neurofibromas with fibrous dysplasia, NOF, that could mean that it's probably a syndrome. In Maffucci syndrome, you can have multiple hemangiomas, especially in the hand region, and along with enchondromas. In Mazabroth syndrome, you can have intramuscular myxomas with polyostotic fibrous dysplasia. And similarly, if you find multiple bony lumps elsewhere, we all know it could be due to multiple hereditary exostosis, Olier's and Maffucci syndrome, both of which encompass multiple enchondromatosis. It could be polyostotic FT. It could be also due to hyperparathyroidism, or it could be due to Jaffe-Campanachi syndrome, in which you find multiple non-ossifying fibromas. Now, this is an example of Maffucci syndrome, in which you see there's multiple hemangiomas involving the palm. And on the right, you see the X-ray showing multiple enchondromatosis and deformities. This is a case of Mazabroth syndrome. So you can see fibrous dysplasia involving both the long bones. And then you see those white things in the MRI. So white stands for a lot of fluid in it. So all of these are stir sequences. So when you see this bright signal, it means it's probably a tumor having a lot of fluid in it. So these are all myxomas. Now, if you have diffuse bony pain, if the patient complains of diffuse bony pain or tenderness with or without palpable nodes, a palpable lump, then it means it could either be multiple myeloma, leukemias, it could be metastatic disease, it could also be hyperparathyroidism or LCH. Now, if you look at this MRI, this is a T1 sequence, but if you look at the bone, what is odd about this is that all the bones look very black. There's no fat in it at all. So all the bones are being replaced by tumor cells. So this is a case of a leukemia, which is causing a lot of back pain and bilateral hip pain in this patient. I come to regional examination. So there are six things that you want to look at. So you want to look at the location, you want to look at tenderness, pain, or limp. You want to describe the lump or the swelling, and then you want to describe a deformity if there is any, and you want to describe the restriction of movement, and also if there is any neurovascular deficit. Now, this is a typical presentation of osteosarcoma in our part of the world. It's usually a school-going child present with antalgic gait. There's a sizable swelling. He might actually be brought in a wheelchair or a stretcher. There's a sizable swelling in the distal thigh with stretched skin, striations, and prominent veins. The rome is restricted, the knee is placed in flex position, and there's loss of muscle bulk all around. The distal neurovascular status is usually intact. So this is how you describe a patient having a large osteosarcoma. Now, coming to location, I think this will be repeated by Rishi again, so I won't go much into this. One thing I would like to emphasize is that you can have patients who would complain of joint pain, and it might not be due to inflammatory arthritis or infection. So you can have a lot of different tumorigenic conditions in which pain could be there. Like it could be geodes due to degenerative disease. It could be due to interosseous ganglion, chondroblastoma, sometimes even clear cell chondrosarcoma. Osteoid tumors can also cause pain. Traverse disease, GCT, SBC, AUC, anything that is small, that that does not have a soft tissue component to it, and is around the condylar region near the joint, can often mimic inflammatory pathologies. Now, if you look at the bottom, acral metastasis is something that you should know of. If you find patients, 50, 60, 70-year-old patient who is a chronic smoker with this very weird lesion in the wrist joint or in the fingers or in the toes, anything beyond the elbow or the knee joint, the first thing you do is get a chest X-ray done, because a lot of them present with acral metastasis, lytic lesion beyond the elbow or beyond the knee joint. So now coming to pain and tenderness, the patient may have superficial or deep tenderness depending on the tumor location and the biology. And the pain may be vague or diffuse as well. So sometimes patients may have, let's say, a sarcoma around the knee joint of the distal femur, let's say. There might be a soft tissue component, which is visible, but then they might have marrow changes right up to the hip joint. So if you examine these patients properly, they might have tenderness right up to the GT, because there's marrow changes right up to the hip joint. So it's important to do a complete examination. Like I said previously, a lot of patients having intra-articular pathologies can have joint line tenderness, which might mimic synovitis. And there's something called tap tenderness. So if you gently tap that area, if the tumor is very close to a nerve or a vessel, sometimes they have tenderness there, which may or may not have a Tinel's component to it. Now coming to lump or swelling, so you want to see the consistency. If it is anywhere soft to firm, it could be anything between bursa or hematoma or soft tissue component of the bone tumor. It could be callosities or lymphomas. Now I've written lymphomas because even when you have like bone lymphomas, sometimes they might have such a big soft tissue component to it. You might be confused as to whether it is a soft tissue sarcoma or a bone sarcoma, bony pathology, because bony lymphomas can have large soft tissue component to it. If it is hard, it could be due to osteoid lesions or chondroid lesions, or sometimes parosteal osteosarcomas. They are present just underneath the skin. They are pretty hard in consistency. Now, the hallmark of all malignant disease is variegated or variable consistency. If you find that, then it is most probably indicative of a malignant bone disease. And margins are usually not discernible unless it's a surface a superficial lesion, like the ones that I said before, like osteoid or chondroid lesions. Now, this is a case of osteoid osteoma. So as you can see, it's in the inferior neck, and there's not much of sclerosis because it is within the joint itself. As you all know, there's no cambium layer present there, so there's not much sclerosis present. Now, this could be easily passed off as a case of synovitis if we don't have any imaging. Now, whenever you see something like this, someone who presents with thigh pain, elderly male thigh pain, chronic smoker, the first investigation that you ask for would be a chest X-ray, because this looks like a metastatic bone disease. Does not fit into a regular bone tumor diagnosis. There's another case, a lesion, lytic lesion in the patella with breach in the cortex. There's no neocortical bone formation, so most likely again a metastatic disease. Now, eccentricity. Now, this is important because when you're examining a patient, you want to see whether the bone is concentrically enlarged or is it just enlarged at one side or eccentrically enlarged. So Rishi will again touch base in this. But if it is, if the whole thigh or if the whole leg is enlarged, then you want to think of diagnosis like fibrous dysplasia in chondromas, chondrosarcomas, or if it's in the diaphysis, then most likely Ewing sarcoma or eosinophilic granuloma or periosteal osteosarcoma. Bone cysts or enchondromas in the early stages don't cause any symptoms. They are usually incidental findings. If they are long-lasting, pre-fracture state, or if they are expansile, then only you can then only they cause expansile bone. And most of the benign aggressive bone tumors are eccentric and expansile. The list is endless. Now, this is a case. These are both cases of low-grade chondrosarcoma causing expansion of the bone. A young child with eosinophilic granuloma. Now, if the child presents to you with a swollen thigh like this, it's almost impossible to say what it is. You can just make an intelligent guess of whether it could be EG or could be infection or Ewing sarcoma. Now, again, if the lesions are multiple, then you want to think of MHE or Olier's or Mafuchi. Now, these are getting repetitive because I'm trying to see this from examination point of view as well. Now, this is a case of Jaffe-Campanati syndrome, in which you see a lot of non-ossifying fibromas along with café au lait and axillary freckling. Now, deformity. Sometimes, bone tumors can cause deformity as well. We all know fibrous dysplasia can cause bowing of long bones. The famous shepherd's crook deformity is usually caused by fibrous dysplasias. There might be anterior tibial bowing. The entire tibia may not be bowed. It's just that the anterior cortex is bowed. So it can happen due to OFD in kids or adamantinoma in adults. Osteoidostoma, long-standing osteoidostoma with a lot of sclerosis can also cause pseudotibial bowing. Progressive bowing of any adult bone is usually due to Paget's. Varum, valgum deformities, forearm wrist deformities, the hand deformities are usually caused by chondroid tumors. So this is a case of Paget's disease in which there is acute bowing of the tibia. This is a case of OFD in a kid, so you can see the bowing there. On the right, you see adamantinoma in an adult causing bowing. It's a case of Olier's disease with hemisonic, so one side of the body is affected. It's a case of shepherd's crook and polyostotic fibrous dysplasia. This is a Masara classification of forearm and wrist deformities in multiple hereditary exostosis. And now this is Trevor's disease. So Trevor's disease is basically intra-articular osteochondromas, and they're very difficult to treat if you find them later on, because all of these angular deformities, it's very, very hard to treat them. And other symptoms include restricted roam. So as you can see in the picture on the right, so this is sessile osteochondroma that can cause restriction of movement. And sometimes you can have neurovascular complications. Like for instance, this is a case report from India, I think, in which they're showing the common peroneal nerve that was impinged upon by an osteochondroma involving the fibular head. This is a case of pseudoaneurysm due to a spiked osteochondroma in the posterior femoral cortex. This has been reported from Japan. And briefly on, so that finishes my clinical examination part. Now, just a quick word. So you can have syndromes in which osteosarcoma can happen. Broadly, there are leaf formini, retinoblastoma, and there are 5 different syndromes in which there are REC4 mutations. So they all have their own clinical features. They're pretty rare, but you have to, if you're interested in oncology, you should know. And I won't go into this. So these are all tumor-like conditions that are much more commoner than tumors itself. So we have general idea about that, like osteomyelitis, different forms of osteomyelitis. If it's a single lesion, different forms of osteomyelitis, stress fractures, myositis, hematomas, melanostosis, or other bone dysplasias and development congenital disorders, they can all be mimickers of bone tumors. Like for instance, if you look at the left, there's actually X-ray of a stress fracture. On the right, it's a picture of a giant osteoid osteoma. So both of them, if you don't ask for the history, they look almost the same. But if you elaborate on the history, you sort of can make a guess as to what is what. On the left is a case of melanostosis. On the right, you see HTO involving bilateral hip joints in the patient with head injury. If there are multiple lesions, it could be anything from inflammatory arthritis, TB, CRMO. The list is endless. And if you have deformities, it could be skeletal dysplasias. It could also be disorders of calcium metabolism. So this is a case of Gaffey's disease. So this child would, if you were to see this child, it would present with increased thigh girth, asymmetric type of increase in thigh girth and leg girth. This is usually a self-limiting condition. Now, finally, I'd like to do a small case presentation in which I'd like to talk about the difficulties of, sometimes managing these cases, in which, you have to have a broad idea of what it could be. So as an orthopedic oncosurgeon, I get a lot of referral of these patients in whom a diagnosis could not be made. So I got this referral for a patient, 30-year-old male with pathological fracture of the right femur. And he had been taking all sort of medications for rheumatoid arthritis and, all sorts of NSAIDs over the course of many years. And he suddenly had this fracture one fine day, and he landed up in the ER. So at that time, at that moment, he was handed over. On elaborating more, he complained of pain in the calf region as well. So we got an X-ray and MR scan. It showed a lytic lesion in the mid fibula. So whenever you see a lytic lesion at a place where you're not supposed to see, so usually when you see a giant cell tumor, it's in either the metaphyseal or the epiphyseal region. But this was bang in the center of the fibular diaphysis. So that raised the suspicion of whether this could be a metastatic lesion or could it be a metabolic condition. So we did his calcium levels first, calcium and phosphorus. So when we saw low phosphorus, that meant that it's probably a good idea to do a PTH level. PTH level was pretty high. USG scan did not show anything. So we did a USG scan of his neck, but did not show any adenoma. So we relied on system UV scan, and it showed parathyroid adenoma. And so following dissection of the adenoma, he's doing pretty good. So with that, I'd like to end this. I think it's very haphazard because there are a lot of things to cover. I'd be very happy if you have any questions. So this is my team here. So we have a very good team that is working around, looking after bone tumor and bone cancer patients. And this picture on the right is when we invited Abhijeet as a faculty to the SFON conference. Thanks.
Thank you, Janith. It was a nice presentation, and it's the first. You are the first batsman, so you're the opening batsman for this series. So it was good hitting by you, good number of runs by you. So next, I'd like to invite Rishi to take his presentation and start what should be the investigations done. So first, we have done clinical examination for bone tumors. So as Dr. Janith insisted, what is the significance of it? It's very important. We are not reading or treating the X-rays. So we should have a very thorough idea of clinical examination. So how a patient should be examined, what should be the symptoms, common symptoms, and what are the signs, and what we should suspect in these patients. So any patient we have seen in our busy OPDs, next is investigations. So Rishi will start his presentation and he will be discussing what investigation should be done for these patients and what is the treatment approach for these patients. So Dr. Rishi has done extensive training in orthopedic oncology, and he is working in Nepal and a good friend of us. So he'll be starting his presentation. So you can start your presentation.
Okay, thank you, Dr. Abhijeet, for this wonderful opportunity. I think, okay, I'll just start. Dr. Janith has very nicely covered the clinical aspect. And now I'll go into plain X-ray radiology. Let's start with this X-ray. Looks like benign, so I have kept all the differential benign, and we'll come later how to approach, how to go to the differential diagnosis and radiological diagnosis this patient. So in any plain X-ray, age, plain radiographic features, and location in bone are very important coming to a diagnosis, radiological diagnosis of bone tumors. Okay, what all things we need to see in X-ray, whether the lesion is single or a multiple. We need to look into the morphology of the lesions, margin, periosteal reaction, zone of transition, cortical involvement, soft tissue mass, which bone is involved and which part of the bone is involved, and whether the lesion is centric or eccentric or cortical. These all things are to be assessed in plain X-ray to come to a diagnosis. So this thing has already covered by Dr. Janith. Age is very important while assessment of patient with bone tumors. Now coming to location in tumors, any tumor, any lesion, epiphyseal lesion after physeal closure, you have to think diagnosis of giant cell tumor. But any epiphyseal lesion before physeal closure, you need to think of chondroblastoma. These are more common epiphyseal tumors. And metaphyseal tumors, benign, simple bone cyst, aneurysmal bone cyst in chondroma are more common. Malignant osteosarcoma, chondrosarcoma, they can be metaphyseal lesion. But simple bone cyst in elderly, in a skeletal mature person, you can find a more towards the diaphysis. So osteoid-osteoma, non-ossifying fibroma, fibrous cortical defect, chondromyxoid fibroma, they usually are metadiaphyseal lesions. And as we all know, Ewing sarcoma, adamantinoma, osteofibrous dysplasia, these are diaphyseal lesions. Now, this is very important whether to look for whether the lesions are centric in nature or they are eccentric, because some lesions, characteristically simple bone cyst in chondroma, fibrous dysplasia, they are central in location, central medullary lesions, such as lesions like aneurysmal bone cyst, chondromyxoid fibroma, or giant cell tumor. These are eccentric lesions. And some lesions like non-ossifying fibroma, fibrous cortical defect, those are eccentric cortical lesions. So this is a case, looks like there is a lytic central lesion there with industrial scalloping, and there you can see the punctate calcifications. Most likely this is a case of enchondroma. This is a case where you can see a solid kind of a periosteal reaction, but this was a case of osteoid-osteoma, and this is a case of a fibrous cortical defect. Now, sometimes parosteal osteosarcoma, more common in posterior aspect of femur. This arises from the periosteum. Sometimes you can see a lucency between the bone and the lesion. Whenever you this kind of radiological appearance, especially in this location, parosteal osteosarcoma is always a differential. Periosteal osteosarcoma, although more commonly seen in metadiaphysis of tibia, is a intermediate grade chondroblastic osteosarcoma, and this perpendicular struct is usually it comes with periosteal osteosarcoma. And then to say whether the lesion is radiologically aggressive or not, margin and zone of transition is very, very, very important. Like this lesion, you cannot make out where the lesion ends and where the normal bone starts. So this typically we describe them as wide zone of transition, and this is a feature of hallmark of malignancy in bone tumors. So narrow zone of transition means you can tell where the lesion is and where the normal bone starts. So this is a narrow zone of transition and sharp margins. This is a feature of benign bone tumors. So as already told, a lesion with sharp margins and narrow zone of transition is radiologically considered non-aggressive, particularly when the margins have sclerotic border. Similarly, a lesion with ill-defined margin and wide zone of transition is radiologically considered aggressive. Geographic lesions are very well-defined lesions, where you can draw like a map of a country. That's why they are called geographic lesions, and these are usually benign lesions. Especially when the lesion is surrounded by sclerotic limb, the differential are always benign. But then sometimes when there is a lesion there, but it is not surrounded by sclerotic limb, that means the lesion, even if it's benign, it is an active lesion. But sometimes, the punched out lesions as described in myeloma or metastasis can also present like geographic lytic lesions without sclerotic rim. Moth-eaten appearance is, when you see multiple small clustered lesions which coalesce and form a poorly defined lesion, and it implies rapid growth, and most commonly seen in malignant lesions, whether those are metastatic lesions or primary bone lesions. Permeative lesion is most aggressive lesion, where you can see small multiple wormholes. They appear traversing through the marrow space with a wide zone of transition, and this is most commonly seen in malignant bone lesions, and sometimes also seen in osteomyelitis and infections of the bone. So now coming to matrix, When we see a lesion there, we need to look at the matrix. Matrix gives us the idea, the origin of the lesion, whether the origin is osteoblastic or chondroblastic or fibrous origin. Now, if you see there is a dense ivory homogeneous blastic matrix, which is called osteoid matrix, and is a feature of osteoid lesion like osteosarcoma. And chondroid matrix are typically described as steeples or punctate calcifications, or flocules we call popcorn calcifications, or we call rings and arcs kind of calcifications. Punctate calcification, flocules, and rings and arc calcification, they direct towards the chondroid origin in a bone. So fibrous matrix, as typically described at ground glass matrix, is a feature of fibrous dysplasia. Now, coming to periosteal reaction, we need to know that whenever there is anything, whether it is blood or pus or tumor between the bone and periosteum, you will give a periosteal reaction. Like trauma or scurvy or bleeding disorder, there will be blood and you will see a periosteal reaction. In osteomyelitis, it will be pus, it will give rise to periosteal reaction, and in tumor, you will get a periosteal reaction. But then we need to look which kind of periosteal reaction are non-aggressive kind and which are more aggressive kind of periosteal reaction. So this is a thin kind of a periosteal reaction. This is a solid kind of periosteal reaction. Thick irregular kind of a periosteal reaction or septated periosteal reaction, they are more usually common with benign bone tumors. So these are called non-aggressive kind of periosteal reactions. So lamellated onion skinning periosteal reaction, perpendicular hair on end kind of periosteal reaction, or sunburst or Codman triangle, these are more commonly associated with malignant bone tumors. So that's why they are considered aggressive kind of periosteal reaction. So except trauma and tumors and infection, there are certain metabolic conditions such as hypertrophic pulmonary osteoarthropathy, congenital conditions like periosteal reaction in a new periostitis in a newborn, trauma, some certain drugs such as hypervitaminosis, prostaglandins are also associated with periosteal reaction. But then from an X-ray, we need to make out whether these lesions are aggressive, periosteal reaction is aggressive or non-aggressive. So you see there is a solid kind of a periosteal reaction. CT scan shows a lesion there with a clear, very nice nidus. It is a case of osteoid osteoma. You see there in this picture, we can see a thick irregular kind of a periosteal reaction, and in the middle picture, you can see the sequestrum visible inside, which was a case of chronic osteomyelitis. And the other one is infantile cortical hyperostosis, also known as cafe disease, which is a self-limiting disorder. And sometimes in metabolic other disorders like psoriatic arthropathy, also you will get solid kind of a non-aggressive kind of a periosteal reaction. The onion skin periosteal reaction typically classically described for Ewing's sarcoma, but also you can have this sometimes in eosinophilic granuloma or osteomyelitis. So this one is speculated hair on end periosteal reaction and the sunburst kind of periosteal reaction are typically described for osteosarcoma, but then can happen with other malignant bone lesions as well. And whenever the periosteum is lifted up with the use of tissue component that we call Codman triangle, typically for malignant bone tumors, and sometimes can be seen in aneurysmal bone cyst or bony infections. Now coming to radiology, what we all think we want to see is whether the cortical destruction and the associated soft tissue component. Any tumor with associated soft tissue component and bony destruction has to be considered malignant unless proven otherwise. There are some benign aggressive bone conditions such as aneurysmal bone cyst or giant cell tumor that can present with soft tissue component, but then any lesion with soft tissue component, you have to think of malignancy first. So whenever there is a bony lesion with soft tissue component, we need to make out whether this is a primary soft tissue lesion with secondary bony involvement, or this is a bony lesion with secondary soft tissue component. In a primary bone tumor, the epicenter lesion is within the bone. The periosteal reaction can be present, and the cortex will be beveled toward the soft tissue, and significant bone destruction will be noticed in a plain X-ray. So coming to, and we also need to think, look whether the lesions are multiple or lesions. Whenever you see multiple lesions in elderly, you need to think of myeloma or metastasis. In young, eosinophilic granuloma has to be considered, and certain conditions such as fibrous dysplasia, eosinophilic granuloma in chondroma, they are also polyostotic conditions also need to be considered. This was covered nicely with Dr. Janith's presentation. So these multiple punched out lytic lesions in case of multiple myeloma. This was multiple, sclerotic lesions entirely all over the skeleton in a 30-year male. He was asymptomatic for this. This was a case of osteoporosis, but similar picture when you see in a 68-year-old male with urinary symptoms, you need to think of metastatic prostate as well. So coming to this was a case of 65-year female who was referred from medicine OPD for incidentally detected lesion in a humerus. And then famous orthopedician has dismissed it, saying it was nothing. Probably he was thinking as a bone island, but then considering the age, 65-year female, you need to rule out whether this is a metastatic disease or not. And on examination, mass was palpated over her right breast. So to summarize, what all things need to be seen in a bone tumor in an X-ray. To look for the aggressiveness, to see the pattern of destruction, margins, cortical integrity, and periosteal reaction. To have an idea about the original nature of the lesion, you need to look at the matrix, and differential diagnosis, you need to narrow down based on age, bones, and location in bone. So this X-ray I started with, definitely whether first thing we'll like to know whether this is benign or malignant, because this is a geographic lytic lesion with very sharp margin and narrow zone of transition with intact cortex without soft tissue component or periosteal reaction. This is radiologically benign lesion. So now differential, how to look at these differentials. First thing, as already told, the lesion is eccentric as fibrous dysplasia, solitary bone cyst, and inchondroma. These are central lesions, Now, if you see the location, giant cell tumor and chondroblastoma, these are epiphyseal lesions. And if you see non-ossifying fibroma, these are cortical-based lesions, and this lesion is medullary-based. And if you see aneurysmal bone cyst, sometimes you can see internal septations which are not there in this X-ray, and so this most likely is a chondromyxoid fibroma. After radiological diagnosis, we do MRI. First thing, you need to include whole bone, whole compartment of bone in your MRI with one joint above and one joint below. Because MRI, it will give us idea about the extent of lesion, status of neurovascular bundle, any soft tissue component, and any skip lesions within the bone. And it also guides us to do the biopsy to target the more representative area and to avoid the necrotic and the hemorrhagic lesion tissue within the bone. So sometimes people do MRI directly for a young male complaints of knee pain. Then MRI shows you a lot of edema there with soft tissue surrounding edema, a lot of marrow edema, but then sometimes first thing you will like to do is X-ray. And sometimes in this was a case of osteoid which are always, if you look at the MRI, it will give you very confusing images in MRI. Other kind of there is some bone lesion with significant edema around the joint. If you do a CT scan, it was a case of osteoblastoma or osteoblastoma. So CT scan is preferred modality of imaging for osteoblastoma or osteoid. And CT scan also we can use to treat these lesions with radiofrequency ablation, CT guided radiofrequency ablation. CT scan, as we all know, also used in metastatic workup to look in the lungs. And CT scan also sometimes we need to do a CT guided biopsies. Now coming to biopsy should be a final diagnostic procedure, not just a shortcut to diagnosis. What information do we want with biopsy? Nature of tumor, whether this is benign or malignant, type of tumor, and grade of tumor. So what are the risks involved with biopsies? Because it is an invasive procedure, because you are violating the compartmental barriers. There is risk of damage to neurovascular structure, risk of hematoma, risk of infection, risk of iatrogenic fracture, and risk of bleeding. So this is not a simple procedure. It's a very complicated procedure actually. So approaches, we can do open biopsy, incisional or excisional, which yields more tissue sample, but then the risk of complications are higher with open biopsies. Nowadays, current gold standard for a musculoskeletal bone tumors is percutaneous core needle biopsy. And FNAC we usually done for other lesions. Usually we don't do in musculoskeletal bone tumors. Sometimes we need fluoroscopy, CT guided or ultrasound guided biopsy to target the representative areas, especially when the lesions are very small and in very close proximity to neurovascular structures. And cytopathology, although the complications, FNAC complications with the FNAC are very less compared to core biopsy, but then we don't want to do FNA for bone tumors because it is difficult to analyze architecture. And without the matrix of the lesion and architecture, you cannot come to a definitive bone tumor diagnosis of a bone tumor. And also histological grading is not possible with FNAC, but sometimes for a recurrent or a metastatic disease you can do a FNAC. Coming to principle of biopsy, should be planned and executed by same surgeon who will be performing surgery subsequently. All radiological investigations should be completed before biopsy. Incision always along long axis of the extremity. Flaps should not be raised, and you have to have your dissection through only one compartment. So never use transverse incision. Avoid intramuscular planes and neurovascular bundles. If there is a soft tissue, it is a very good, sample can be taken from the soft tissue as well. You achieve meticulous hemostasis, and drain, if you want to insert, should exit in line with incision. Now, if you see for proximal femur, for medial bone lesions, medial bone lesions in the proximal femur, these are medially, you can go through the adductor compartment. For lateral lesions in proximal femur, you go through vastus lateralis. For distal femur, you can go anteromedially through vastus medialis, or you go through vastus lateralis. For tibia, proximal tibia, medially the tibia is subcutaneous, so you can directly go to the bone. And if the laterally you want to go, you have to go through the tibialis anterior muscle. Proximal humerus, from where to go, you go lateral to the deltopectoral groove through the deltoid fibers. Humeral shaft, you go lateral to the bicep muscle, and distal humerus, you go directly over the epicondyles, or you go anterolaterally through the brachialis muscle. For radius, you follow this limb salvage incision, we call it, forms the aponeurosis, bicep tendon above to center of the wrist. Ulna, you can go direct to the bone because the ulna is subcutaneous. Fingers, you go through dorsal or lateral incision. Metacarpals, you go straight dorsal incision. Yes, there is a lot of controversy whether biopsy tract need to be excised or not, but then most authors advocate the removal of biopsy tract along with the tumor during final surgery. Now, after coming to biopsy, and what are the imaging, we want to do the staging of a tumor. CT thorax, bone scan, we commonly do for osteosarcoma. In addition to CT thorax and bone scan, we need to do bone marrow aspiration for Ewing sarcoma. And now, bone marrow aspiration in Ewing sarcoma, a lot of papers are saying that in a non-metastatic Ewing sarcoma, non-metastatic on chest X-ray or bone scan, the yield of bone marrow aspiration is, the chances of bone marrow metastasis is very rare. And even if you want to do bone marrow biopsy, can PET replace bone marrow biopsy? Yes, PET is superior to compared to blind bone marrow aspiration in case of Ewing sarcoma. So when you see whether PET scan versus bone scan for bone metastasis, bone scan is as sensitive as PET CT for detecting bone mets in osteosarcoma. However, in sometimes in metastasis with Ewing sarcoma, PET CT is superior in detecting bone metastasis. Now, another thing is PET CT is less sensitive in detecting smaller lung mets, sub-centimeter lung mets, as compared to CT scan of the chest. Now, coming to when you in an elderly patient, when you suspect metastasis, as already discussed, we need to review the symptoms, fever, sweats, and chills, weight loss. They are more common with lymphoma, shortness of breath, hemoptysis, chest pain. You have to consider lung metastasis from lung, breathing difficulty, hematuria. You have to think of renal or prostate mets, breast discharge or breast mass. You have to think of metastasis from breast, rectal bleeding or anemia. You have to think for some malignancy from colon. Physical examination, you look to like to see whether there is jaundice, any neck nodules, axillary nodules or lump. And you need to auscultate the lungs. You need to see for hepatosplenomegaly. And this blood investigation we very commonly do, CBC with differentials, sometimes multiple bony lesions and multiple myeloma. You will get this anemia, you'll find anemia, high ESR, calcium phosphate, alkaline phosphatase, you have to do to look for the marrow amount of bony involvement. Urine analysis you can do for, to rule out hematuria. ESR, CRP, sometimes, we need to do because sometimes bony infection, they mimic bone tumors. PSA, when you are suspecting metastasis from prostate, you do PSA. Serum electrophoresis or urine electrophoresis, you need to do to rule out multiple myeloma, and also PTS, because sometimes multiple lytic lesions, we are thinking even if you do biopsy will suggest giant cell lesion, then you do PTH, the PTH is very high. So especially in lytic bone diseases, you need to do PTH to rule out hyperparathyroidism. So a lot of people do fix the bone, fix the lesion, metastatic bone lesion, and then send the remains for biopsy, which is not ideal because the destructive shearing forces, that damages the tissue and the quality of tissue has been compromised. So what will you do when you are suspecting, metastatic bone disease and the primary is not identified? If you think it's a myeloma on your radiological and on your laboratory thing, then you need to do a skeletal survey. For myeloma, we don't want to do bone scan, but then primary, it doesn't look like myeloma, then you need to find out primary. Then we always advise bone scan and CT chest, abdomen, and pelvis. And if you identify the primary, you treat accordingly. But if it's only a solitary reason and primary not identified, then consider this is a primary malignant bone tumor and refer to orthopedic oncologist. And if you have multiple bony lesions and primary not identified, then you have to perform biopsy. But in the case of non-primary, if there is a suspicious lesion, then you can you have to see whether this is monostotic or polyostotic. Polyostotic lesions will the lesions where there is a chance of fracture, you have to stabilize, and maybe you need to send for radiotherapy. But even non-primary monostotic lesions, only one lesion is there in entire skeleton, you need to perform biopsy, and you have to refer to patient to sarcoma surgeon, because the key intent is still curative, and patient might need wide resection of the lesion. So I'd like to thank you, everyone.
Yeah, Rishi, it was a nice presentation. So you set the stage for next presentation. So we'd like to, I'll share my screen.
Thank you.
So good evening, friends. My presentation is on the first webinar. So our first webinar is on clinical features, investigation, and A to Z RAM, so radiographic assessment method. And this will be a series of webinars. So we'll be trying to conduct it every month at least twice. And this will be a part of A to Z of orthopedic oncology. So my presentation is on A to Z RAM. So what is meaning of this A to Z and RAM? So RAM is a radiograph assessment method for patients with suspected bone tumors. So like Dr. Janith said, clinical examination is important. So this is a slide showing that there is lesion in the radius, some swelling, which is the skin looks tense, shiny, with some dilated veins, both on the dorsal and volar aspect. So we are suspecting some lesion which is involving the distal end of the radius. Patient is having no history of trauma, and there is a swelling for few months duration. So the duration is of few more months, and on clinical examination there is a tenderness and local temperature is raised. So what is the next investigation? Like Rishi said, the investigation should be a X-ray, which will be followed by blood investigations, what he had described, CBC, ESR, basic blood investigations. It will be followed by a MRI based on what is our diagnosis, and we can plan the treatment. So after clinical examination, next investigation will be a X-ray for the patient. So in India, we always have fascination of Bollywood and cricket. So it's like Virat Kohli suggesting what should be the treatment plan next. Either we should have a spinner, leg spinner, off spinner, or a fast bowler, which should be a fast bowler, it should be a swing bowler. So next investigation will be a X-ray followed by MRI. So plain X-ray we'll ask for blood investigation, followed by MRI, followed by biopsy if required, and staging investigations, as Rishi had described very well. It will be bone scan, CT thorax, or PET scan as per the lesion. So this is just a rough idea that what should be the diagnostic investigation, what should be the staging investigation. It all totally based a combined effort. So it's combined effort from clinical examination, X-ray, MRI, and next investigation should be planned according to that. So this is the X-ray of the patient. So there is a lesion in the distal end of the radius, and MRI was done, and we will see how we should read a X-ray. So why it is important? So on the left side, there is X-ray involving the femur bone, proximal femur in a young girl, and there is a lesion involving the proximal femur. Sorry for the poor quality. This was the referral X-ray to us, and we had performed X-ray and other investigations for this patient later on. So on the right side, we can see again Bollywood. There is Amrish Puri and Shah Rukh Khan sitting beside each other. So whether Amrish Puri is benign, so on the left side he is benign, on the right side he is malignant. So multiple of its villainous acts there. So whether this X-ray looks to us benign or malignant, and treatment plan totally depends on that. So we can see this X-ray and keep in our mind this looks what to us, benign or malignant, like Amrish Puri, which is benign or malignant on this slide. So this was thought to be benign by the treating orthopedic surgeon, and he had put Ender's nail for the patient, and the swelling increased in the size. So the disadvantage was after putting the nail, it was a tumor and it increased in size. So he suspected it was an aneurysmal bone cyst, and he had put nail to prevent fracture, pathological fracture. And this turned out to be sarcoma, and it was referred to us at our cancer center. So we investigated the patient, we did a MRI, we did a CT scan, and we did a biopsy for this patient, and it was Ewing sarcoma. So again, same analog from Bollywood, Kajol missing the train and she couldn't catch Shah Rukh Khan, and we had to bang our heads because it was Ewing sarcoma. And we treated the patient with chemotherapy. And on the right side, we can see a X-ray where the lesion has healed very well. So as compared to previous X-ray, it has healed very well. So if you can see this X-ray, it was a big lesion, nail just coming out of the femur. And on the right side, the X-ray showing it's very well defined now. It's a good response to chemotherapy, and patient didn't have any lung mets. So we thought that we'll treat this patient with limb salvage surgery. So if it was not a rodded sarcoma, so what that is the term, we are putting a nail or plate inside a sarcoma without having proper diagnosis and just putting a nail or plate. So there is a term called rodded sarcoma. So we have two treatment options, either limb salvage or amputation for these patients. So for this patient, we had planned limb salvage surgery, and this is the biopsy scar. As Rishi had told, we should excise the biopsy scar. It's very good idea to excise because very high chances of tumor sitting inside this biopsy scar. So we had planned total femur excision for this patient. So on the right side, we can see whole of the femur is excised to the lateral approach, and the whole bone was resected. So we can see the histopathology specimen, and this was a cut specimen. We can see the nail protruding out of the femur. So this was rodded sarcoma treated with a total femur excision, and we had to perform invasive type of minimal invasive type of total femur megaprosthesis. So we had planned the customized joint for this patient. So just a small video showing what is total femur expandable prosthesis. So we are turning the threads of the screw, and the center part is expanding. So this is minimal invasive type of expandable megaprosthesis. So this is the expanded area we can see here. So next is again a second case where this is quite big lesion. Someone again thought that it's a benign lesion and put a nail inside it, and we can see it's too big lesion. It's not salvageable, and the patient had lung mets on presentation. So we had to treat this patient again with palliative intent. Third case, fracture into the femur, again thought to be myeloma or metastatic lesion. The surgeon put a nail. So on the right side, we can see the X-ray after nail. Left side, we can see the X-ray before nail. And this was quite big lesion, 55 years old lady. This was osteosarcoma, and treated with external hemipelvectomy, amputation of the limb, and the patient had bad prognosis. So can we prevent this? Yes, we can prevent this. So rodded sarcoma is a tumor which is thought to be benign or metastatic lesion, and we are putting a plate or nail. And final histopath, it's the OOP surgery. What we think it was a benign tumor, it turned out to be osteosarcoma, Ewing sarcoma, or chondrosarcoma. So we can treat them with limb salvage or amputation. Again, very bad prognosis. Patient survives very less because of putting nail or plate inside this patient. So what Rishi has said, we'll describing same things. We are having a patient with bone tumor, and we are getting his X-ray. So we should know the age, the gender of the patient, single or multiple, location on the skeleton, location, which bone, which part of the bone, periosteal reaction, border, destruction. So this looks quite busy slide. We are seeing sitting in our OPD, and we are sitting 50 to 100 patients daily in our OPD. It's very difficult to read a X-ray based on this pattern. So age, gender, single, multiple, and we are having very much difficulty to reach a diagnosis based on these busy slides. So we thought that we will make a simple method which can be easily used by any orthopedic surgeon or oncosurgeon or medical oncologist when he's seeing a patient, and we can reach some diagnosis, and later on a good treatment can be planned for him. So we published a paper that is proposed A to Z RAM radiographic assessment method for triage of patients with suspected bone tumors. So the work was performed totally at the GCRI, Gujarat Cancer Research Institute. We had good collaboration with an engineer and orthopedic colleague. And this paper was published in a radiography journal in January. So last month only we got published this. So we'll be discussing all the things which were based and why this paper was published and what was the idea behind it. So we will be classifying this all things: age, gender, single, multiple, location on the skeleton, periosteal reaction, border, destruction into a simple formula-like thing, which will be difficult to miss in a busy OPD, or it should not be missed by any residents. If any orthopedic residents, oncology residents are seeing our lecture, it will be very useful for them for their examination purpose to pass the exam, and for the clinicians, it will be very easy to reach a diagnosis. So we are using a simple mnemonic, that is A to Z: A, age; B, bone, which part of the bone; which bone; C, characteristic; C, content; D, distribution; E, exterior of the bone; F, fracture; and Z is zone of transition. So like what we had learned ABCD in our childhood days, we are using same formula: A, B, C, D, E, F, and Z. So Z is the last letter, last alphabet. So A, age, whether the patient is skeletally mature or immature. So what Rishi described, few tumors are common in pediatric age group, few common in adult age group, like Janith also had described. So primary bone tumors common in pediatric age group can be benign or malignant. If the age is more than 50 years, senior elderly person, more commonly it can be a metastatic lesion, but still it can be a primary bone tumor. Then bone, which bone is involved, either it's a long bone or flat bone. Few tumors common in long bone. Osteosarcoma is common. Flat bone, Ewing sarcoma is more common. Chondrosarcoma is more common. Then next is B, which part of the bone. So end of the bone is epiphysis, middle part of the bone is diaphysis, and the part which is adjacent to the epiphysis, that is called metaphysis. So epiphyseal tumors can be chondroblastoma, benign tumor. Metaphyseal tumor can be a giant cell tumor which can extend into the epiphyseal area, and diaphyseal tumor more commonly can be Ewing sarcoma. Next is the lesion characteristic, how the lesion looks, whether it's osteolytic, it's osteosclerotic, it's or a mixed lesion. Next again, see content. How is the matrix? What is the content of the tumor? They're osteoblastic, chondroblastic, ground glass like appearance. These distributions, so well defined or ill defined. Next is exterior of the bone. How? So we are going one by one each part. So E is exterior, periosteal reaction, soft tissue mass. F is for fracture, pathological fracture, and Z is zone of the transition. So we should remember this very easy formula: A, B, C, D, E, F, and Z. So we'll see in detail what is this A, B, C, D, E, F, Z. So we had prepared a easy algorithmic approach. We are seeing a patient in our clinical OPD or in exam. So it's a suspected bone tumor or pathological fracture. We had done radiological investigation, that will be a X-ray, and blood investigation as previously described. So CBC, ESR, calcium, alkaline phosphate, protein, electrophoresis. The patient will have history. So as Janith has described very well, history is very important, whether any history of trivial trauma, clinical feature like pain, swelling. Then next we will apply our formula, easy formula, A to Z RAM. So A, age; B, bone; C, characteristic; D, distribution; E exterior, F fracture, and zone of transition. And this will lead to some idea whether it's benign or malignant. So we are not sure 100% on X-ray whether it's benign or malignant. Still, we can reach some diagnosis and we can treat the patient in more better way as compared to a gross method that it looks benign to me or it looks malignant to me. So use this simple formula A to Z of a radiographic assessment method. So we'll be seeing few examples. So on the right side, there is an X-ray showing a lesion into a age. So age is here. We'll start from age. So we can see a black triangle showing the physis is open. So he looks skeletally immature. Next is bone. So we can clear cut see it's a femur bone and lesion is involving the metaphyseal part and the diaphyseal part. Next is see characteristic. It's an osteosclerotic lesion. It is having osteoid matrix. So what is meaning of this osteoid matrix? It's cotton-like, fluffy cotton-like areas. Next is destruction. There is no cortical destruction seen. So we have seen characteristic, content, and cortical destruction. These distribution. So does this lesion looks well defined or ill defined? We are unable to see or define where the tumor is starting and where it's ending. So it's ill-defined lesion. E exterior of the lesion. So it's a sunburst pattern, periosteal reaction with Codman's triangle. So what is Codman's triangle? That will be described in next lecture, next second webinar. We will be seeing all these features on X-ray. So we'll have at least 2 to 3 webinars on X-ray only, then followed by CT scan and MRI. So F is the fracture. We are white line showing a fracture, that is a pathological fracture. And lastly, Z, zone of transition. So like Rishi described, zone of transition means we can draw a boundary of a country. So where the country is starting and when the country is ending. So that is a geographic lesion. So this doesn't look geographic to us. It's a wide zone of transition. So all these features combined, this radiograph suggests to be of a malignant bone tumor. So if the examiner asks you as in exams, so what is your differential diagnosis? Most probably this looks to us a osteosarcoma. So in our busy OPD, we are seeing this patient and this looks to be a osteosarcoma. And what should be the next line of treatment that we'll be discussing in subsequent slides. So based on A to Z RAM, radiographic assessment method, this X-ray looks to us a malignant bone tumor. So next is a second X-ray, again same age. So your physis is closed. Which part of the bone is involved? It's again a femur. Which part of the femur? Metaphysis and diaphysis. Characteristic, this looks to be a osteolytic lesion. It is having no content and there is no cortical destruction. It's very well defined. The black arrow is showing where it's starting and where it's ending. So very well defined lesion. Exterior, there is no periosteal reaction. There is no soft tissue mass in this lesion. There's no fracture. It's a narrow zone of transition. So we summarize all the findings according to A to Z RAM. It looks to be a benign bone tumor. And again, if we want to have some differential in our mind or asked in an exam, it looks giant cell tumor most probably. Next again, X-ray of a skeletally immature person, lesion involving the humerus bone. Whether it's osteolytic or sclerotic, this looks sclerotic. Osteoid matrix, cortical destruction, periosteal reaction, soft tissue mass, without a fracture. Again, we summarize all the findings according to A to Z. So it looks to be a malignant bone lesion. If you want to reach some diagnosis on X-ray, it can be a osteosarcoma of humerus in a kid. Next, we'll see a X-ray of hand. So this is a lesion involving the third finger, middle finger, involving the proximal phalanx. It is an osteolytic lesion with a pathological fracture. So our differential can be a giant cell tumor. Most probably it can be a enchondroma. So we have to summarize all the findings. Just don't jump to the diagnosis, it looks benign or malignant. Just try to evaluate the X-ray according to all these features and you will not miss any important point, because if we are in a OPD and we are seeing multiple patients, it's very high likely that we'll miss some important findings and the diagnosis will be difficult and we may end up in a rodent sarcoma-like situation. So what is significance of this A to Z RAM? If the lesion is benign, suspected benign, and what should be the treatment for it? We will go for MRI. blood investigation, biopsy if the lesion is requiring a biopsy. We don't do biopsy for osteoid osteoma. We don't do biopsy for osteoid chondroma. But all other benign lesions, what we are suspecting, we do biopsy for these lesions. And if we are suspecting it's a malignant lesion, based on all these criteria, it's very good idea, get a MRI done and send him to, or him or her, the patient, to a referral cancer center, to a tertiary cancer care center, where all his management will be performed. So don't waste his time or your time treating that patient. It's very good idea, get a MRI done and send the patient to a tertiary cancer care center where all his management will be done. What Rishi had said, biopsy is very important. It should be along the final line of incision. So the surgeon should have know all the important steps. It's very good idea. Just refer him to a tertiary cancer care center. So what are the features of benign bone tumor? It's a well-defined, narrow zone of transition, no content or chondroid matrix in enchondroma, benign type of periosteal reaction. So all these features suggestive of, so again, I will insist this word suggestive. So X-ray is not and never a final criteria to reach a diagnosis. It's always first investigation, and it's very good idea to get what is the lesion. So based on this, it's suggestive of benign bone tumor. And a malignant bone tumor, it will be having cortical breach, it will be ill-defined with a wide zone of transition, osteoid or chondroid matrix, and malignant type of periosteal reaction. Again, I will insist, it's suggestive of malignant bone tumor. And how we treat them? It's good idea. Suspected bone tumor, get a MRI, get a biopsy. If you are suspecting a malignant bone tumor, get a MRI and refer him or her to a tertiary cancer center. So we had made a easy pyramid here with in the green zone like a signal. So signal is universal all over the world. It's green. So you can go ahead with MRI and biopsy. If we are suspecting any malignant bone tumor, I'll again repeat this word. If we are suspecting any malignant bone tumor, just refer the patient to a tertiary cancer care center for better management. So we'll see few examples. So X-ray involving the radius. So again, we apply our knowledge with A to Z RAM. This looks to us a benign bone lesion, and MRI can be performed for this patient, and we can treat him with a biopsy. So this was most probably a giant cell tumor. Second, a case of skeletal immature person, lesion involving the metaphysis, diaphysis. This looks to be a ill-defined lesion with a periosteal reaction, with some soft tissue mass, without pathological fracture. So again, we apply our knowledge, and it looks to be as a malignant bone tumor, and this was osteosarcoma. Again, a lesion which is quite big in size, involving the proximal tibia, so whole of the tibia is involved, epiphysis, metaphysis, part of the diaphysis. The important characteristic, it looks well defined, and without any periosteal reaction, some soft tissue mass. So we had got MRI done and biopsy. It was a giant cell tumor of the proximal end of the tibia. Then again, same X-ray, X-ray of the skeletal immature person, humerus involved, ill-defined periosteal reaction. So again, apply all our knowledge, and the X-ray should be a full length. So again, a learning lesson, X-ray of a bone tumor should be full length of the bone should be screened, because it may have skip lesions and other lesions. So it's very good idea, screen the whole humerus, whole femur, whole tibia, whichever bone is involved. Next X-ray, we can see lesion involving the diaphyseal area, metaphyseal area, periosteal reaction, ill-defined. So this looks, soft tissue mass is present. This looks to us a malignant bone tumor according to all our features what we had learned previously in this topic. So again, this is important. Suspected benign bone tumor, MRI, biopsy as per the bone lesion, and suspected malignant bone tumor, get a MRI and referral to a tertiary cancer center. So what are the implications of A to Z RAM in our clinical practice? It's a very easy and reproducible method for reviewing radiographs in our outpatient departments. Whenever we are seeing any patient in our OPD, just we can have idea, just write on a paper A to Z RAM and write all these features, and it will summarize all the findings, and it will give very good idea that we don't miss any important find. And second, it can aid in better management. If you are suspecting benign tumor, what should be the management, and what is the malignant tumor, what should be the management. Second is it's an easy triage method. So what is meaning of triage? If we are in a war-like situation, we do to triage of the soldiers which are wounded due to any casualty there happening there. So we separate them into two categories, which can be salvaged, which can't be salvaged. So here, this can be easy medical triage system. Benign tumors, you can get an X-ray, MRI, or biopsy. Malignant tumor, get an MRI done, and refer to a tertiary cancer center. We can subdivide them according to suspected lesion, which is benign, or suspected malignant lesion. So I'm very much thankful to all our faculties which were here, Dr. Rishi, Dr. Janith, and Dr. Ashok Shyam sir, who had supported us for starting this webinar series. So today only we like to announce there will be next webinar. So second webinar of this series, A to Z of Orthopedic Oncology. Again, it will have radiographs of benign bone tumors, radiographs of malignant bone tumors, and we will be going into more details. So what is osteoid matrix? What is chondroid matrix? What is periosteal Codman's triangle? So it's not a triangle, it's a mesonomer. So we'll be seeing all these features in detail for next 2 to 3 webinars. What is radiograph of a benign tumor? What is radiograph of a malignant bone tumor? And what are the features? Again, it will be next week. So again, Sunday. And I think we are trying to finish it. It's 6:31. Just had exceeded for a minute. So we'll try to finish it next time in exact 1.5 hours, so that we can have very good idea of orthopedic oncology. And basic purpose of starting this webinar is to get sensitized all our orthopedic surgeon friends, oncologists, students who are graduating their orthopedics, that they will have good idea of orthopedic oncology, and they can treat the bone tumor or soft tissue tumor patients in a more better idea, so that we can share our knowledge with all of them. So if you are having any queries, you can just email to my email ID. It's bonestumor@gmail.com, or you can email any of your queries to Dr. Ashok Sham sir or any of our faculties. We will be happy to discuss them, all the queries in next webinar. So at the end of this webinar, I'll again announce that we are having a second webinar next week, next Sunday. So we'll be going more details of radiograph of benign bone tumors and malignant bone tumors. So so all our faculties and Ashok Sham sir, we would like to conclude this seminar webinar first, and any discussions we'll try to finish it bit faster so that we can discuss more cases. So next time we will try to finish it exactly, and we'll have few cases next time that we can discuss it. Any comments from our other faculties, Janith and Rishi? So we can improve this presentations and webinar according to all our comments of our faculties and all our audience. So Janith, any comment from your side?
I think we are also learning as to
So we
what's
all are
important to
learning.
discuss and what's not.
So the purpose of starting this webinar is just not to teach. It's we are still learning. So that there is never end of learning. So that is the crux of this webinar series. That learn, discuss, and again learn and discuss.
Right. The thing is, if you look at the standard textbooks for orthopedic oncology, there's not much. So
yes. So
when I was trying to make this presentation, I had to go back to my own knowledge and then look for tidbits here and there.
So make all the
presentations. Put it all together.
So nothing is available. That's the thing. In textbooks,
but that's
very
fun.
less available.
Fun as well.
Yes, so that is important. Yeah. So we'll
thank
try to
you
improve our
much,
presentation.
Thank you, Dr.
Thank you very much. Yeah, Rishi. So anything from your side?
Dr. Abhijeet, it was very nice, but next time maybe we'll try to stick to our time, so there's some time.
Time is not an issue. We will try to finish. We are 1-2 minutes ahead of our time. So that is very important thing. We'll stick to our time. And we'll try to make improvement our presentation. Yes, Ashok sir.
Yeah, I think it was a very good beginning for this series. And like you said, we evolve and learn, take feedback from the audience, and improve and improvise as the feedback comes in. So
yes, definitely.
Thanks again, all of you.
So again, we will be having next webinar next week, next Sunday, sir. Yeah. Thank you very much, sir. Thanks to all for attending this. Thank you very much. Thanks, sir. Thanks, Rishi. So we'll end our session here today. We'll see you all